Yeah, there we go. Very welcome, everyone. We're just going to just wait a minute or two and let people join. Okay, thanks for joining us tonight. Welcome, everyone. We're going to just give it a minute or two and just let people join. So thanks so much for joining us this evening. Okay, well, we might just start to kick it off. I know there's a few people that are still yet to join, but for those who are here right now, thank you so much for joining this evening. My name is Aoife Breslin, and I'm the head of marketing and comms for Sims IVF. So just a little bit about Sims IVF before we start. So our parent company is Virtus Health, so they actually have clinics all throughout the world. Really, they're pretty global, so they're mainly based in Australia, but there's clinics in Singapore, in Denmark, and the UK. So we have a great network of support. Sims IVF ourselves, we have actually 6 locations in Ireland. So we have 3, what we say are like our main clinics. So we have one in Clonskeagh in South Dublin. We have one in Swords in North Dublin. That's where Clara is based. And then we also have one down in Cork. And then we also have what we call satellite clinics. So these clinics will kind of support you through your cycle. So they'll be able to provide bloods and scans so that you don't have to make as many journeys to the main clinics. All the major procedures like embryo transfer and egg collection will all happen in the main clinics, but the satellites will be there to support you. So, it just eases the travel a little bit. So I'm just going to hand over to Clara now. And oh yeah, just one thing, if you have any questions or anything like that, please pop them into the Q&A box and we will answer them at the end. But yeah, I'll hand over to Clara now. And yes, best of luck.
Thank you, Aoife. So yeah, thank you for that, Aoife. My name is Clara, as Aoife said, and I am the nurse manager at Sims IVF Swords. Today, I'm here to talk to you about fertility treatment and how to begin your fertility journey. With particular emphasis on, I suppose, the different pathways that people can take, namely the go privately self-referral, or with the public route, the HSE public funding. In addition, I'm going to talk to you a little bit about the investigations that are often recommended for women or for couples and the different treatment options available. So a good place to begin when we talk about fertility is just kind of exactly what is infertility and its incidence and how it might be subdivided. So infertility is defined as not being able to conceive after 1 year of trying to conceive if the woman is less than 35 years of age. Or after 6 months, 6 months if the woman is older than 35 years of age. Its incidence is high. It's 1 in 5 couples, which I know this incidence is thrown around quite a lot, but it's quite significant. It is particularly high. Infertility can be subdivided into either primary infertility or secondary infertility. Primary infertility being when a pregnancy, it's never been achieved before, or secondary infertility when at least 1 pregnancy has been achieved. Infertility is recognized as a disease by the World Health Organization, and that is thankfully reflected by our Department of Health since November last year with the introduction of the public funding scheme for fertility treatment as well. Again, I'm just giving a little bit of a background about infertility before I dive straight into different pathways and treatment options that are available. But it's when you kind of break it down, when we look at that kind of the causes of infertility, there's 3 factors, namely, that will lead to a pregnancy. And that is egg, sperm, and the environment, which is the womb or the uterus. So when we talk about egg, it might be an issue with egg quality or the supply or the quantity, the number of eggs. We know egg quality will deteriorate gradually with age, as does as does our egg supply. There are investigations available that can check our egg supply, or what's called our ovarian reserve. Unfortunately, there's no test in Ireland, or in the world, I should say, that can test a woman's egg quality. That's only seen in embryo development, a positive pregnancy, but ultimately with a live birth as well. Sperm, of course, we need sperm to have a pregnancy. When we look at sperm, it's particular emphasis on the sperm count, the motility of the sperm. So that just means that of the sperm that's there, are the sperm moving, and then the morphology of the sperm, which means the appearance of the sperm. Does it have a head and does it have a tail? Lastly, the environment. So when I say the environment would be the uterus or the womb itself that accommodates an embryo to implant and therefore a pregnancy to grow. So factors such as uterine fibroids or little polyps in the lining of the womb or endometriosis, these are all examples that might contribute to infertility. In addition, we also when we talk about the environment, you're also taking into consideration the fallopian tubes. Of course, for pregnancy to be achieved, at least one fallopian tube needs to be present. It needs to be open or patent to ensure that the egg that is released can travel to meet the sperm, and then the embryo travels to the uterus as well. This is just a pie chart, just the causes of infertility kind of broken down a little bit. So when you look at this pie chart, you'll see 30% of the causes of infertilities are attributed to male factor. Another 30% are attributed to female factor. Other contributes to 5% of the causes of infertility combined. So it's a combination of a male and female factor would be 10%. And lastly, unexplained would be 25%. I always think the unexplained is quite high. It's just 25%. What this means is that when a couple come to a fertility clinic, they have their initial consultation, and the doctor recommends that they have all the routine investigations. And then all these investigations, the results come back as normal. This would be then considered unexplained infertility. And you might think it's like, oh, well, that's brilliant. Everything has come back normal, fantastic, we'll just carry on. It can be quite frustrating for these people because as humans, we kind of think it's like, okay, well, there's a problem. Let's get to the source of the problem. Let's fix it. That said, there's generally a solution. There's a solution for everything, and it does open multiple treatment options then for that couple. We've all heard of the biological clock. I don't particularly like this slide, but I do think it's important just to touch on it basically. Certainly as women, we feel pressure to get pregnant in the peak of our younger years, something we're all aware of and happens to most of us, that as we get older, our fertility will gradually decline. It is true that age does matter, but in a physiological way and kind of in recent years, we do have a little bit more control and more power in taking action of our fertility, particularly in terms of kind of fertility preservation. So for patients or for women or for couples or men, I should say, but who choose to freeze eggs or embryos. So where to begin? There's two routes. Okay, so if you're in a position where you want to start a family, you want to expand your family, children is just something that you want in your future. You may be single looking to use donor sperm. You may be in a couple or a same-sex relationship. This is just a little bit of kind of information that's very appropriate for you. But there's two routes. There's the self-referral, which is the private route, and there's the HSE pathway, which is your public route. Just to begin, we'll just touch on the private pathway first. If you're interested in fertility treatment, we'd ask you to come to our website. It's www.sims.ie. Like most websites, most fertility clinic website, it's very, very user friendly. You'll see kind of on the website, on the homepage, there's on the top right hand corner to press the option to request an appointment. When you click that option, you'll be asked just to fill in your details, so your name, your phone number, your email address, and with that, a patient coordinator will then be in contact to arrange a doctor consultation and discuss different fertility packages available to you. You might think, fertility packages, well, they're trying to kind of sell. That's actually not the case at all. So when we offer a doctor consultation, it's good to kind of make the most of that consultation. So instead of just coming to the consultation with no investigations, no results to work off, it will be it'd be more worthwhile if you had some blood tests, a semen analysis, maybe an ultrasound scan in advance of that appointment. So the doctor can then review the results of those investigations and kind of move forward, whether it's to recommend further investigations or generate a treatment plan for you. So those fertility packages discuss different investigations that include what I've just mentioned and a consultation as well at a discounted price. Once you have an appointment with a fertility consultant, they'll review or recommend, as I said, investigations for you or generate a treatment plan at that point. Just continuing with the private pathway, once you've had a doctor initial consultation, as I've already said, there's different kind of packages available to you. And if you choose not to go for that package, which you're perfectly entitled to do, we would ask that if you've any test results or relevant referrals or medical notes, that you submit them to us in advance of the consultation. Again, just to make the most of that appointment. Again, if you choose not to, if you don't have any results or you don't wish to proceed with any of your fertility packages, that's perfectly fine. There's really no pressure at all. Once you've had that consultation with the doctor, you receive a phone call from one of our nursing team. Within a day or two, really, after that consultation. The nature of that call is really just to provide you with information about the clinic, in particular, maybe just the drug payment scheme card that's available to all residents of Ireland, the pharmacies that we'd recommend who specialise in fertility medications. We'd summarise the conversation that you've just had with the doctor, plan any investigations that have been advised, and address any questions that you might have at that stage as well. We do all investigations in the clinic, but of course, you're most welcome if you wish to kind of do your investigations with your GP or externally. That's also perfectly fine. Investigations, I've touched on that already. I'm going to go into a little bit more detail about that in my next couple of slides as well. If required, you then have a doctor return consultation. This is normally over the phone or maybe Zoom. And I should have said, sorry, the initial consultation, we would recommend to have it face-to-face as well. It gives you a feel for your doctor and for the clinic and for the staff that are in the clinic as well. It's a nice opportunity to come in at that point. Return consultation, if you wish to have it over the phone, that can be arranged. The nature of this consultation is to discuss the results of the investigations that may have been performed and to generate a treatment plan based on you, and if you're in a couple, your partner's history and results. When we talk about treatment plans, it can really it's vast. We do a lot of treatment options, but it can be anything from an ovulation induction or time-second intercourse cycle all the way up to IVF or a pre-genetic testing cycle. And again, I'll touch on that in a little while as well. Once you've had that consultation with the doctor for a second time at the return consultation, a nurse will call you then after. So that phone call, it'll be usually maybe 3 to 5 days after that consultation. We call it a nurse scheduling call, simply because we want to schedule your treatment cycle for you. There's no pressure that you have to proceed on a given week or month or date, but we would ask that you kind of take into consideration if you've had any holidays planned, work events, weddings, things like that, and we can plan the dates around those events. Once the schedule call is complete, we'll get you started then with your treatment cycle at your chosen time frame. So for the public pathway, it's a little bit different. So for the public pathway, the first place to start is with your GP. If you're experiencing infertility, if you've been trying to conceive for some time and it's not happening, your pregnancy hasn't been achieved, or recurring miscarriages, we recommend that you go to your GP and you talk to your GP. At that point, the GP will decide if you meet the criteria for this public pathway, and we'll send a referral to your local regional fertility hub, and there's many of them across the country. With that, then the fertility hub will contact you to arrange investigations to be performed. Again, I'll touch on those investigations in just a few minutes. And once you're being approved by the fertility hub, the consultant at the fertility hub will recommend a fertility treatment and refer you on to a HSE approved fertility clinic of your choice. All of the main fertility clinics in Ireland have been HSE approved. They've all tendered and have all been successful for the public scheme. So it's entirely up to yourself where you choose to go. From a convenience point of view, most patients will choose the clinic closest to their address. Once we receive a referral at Sims Clinic, you'll be contacted by a patient coordinator to arrange an appointment with a consultant and to plan your fertility treatment cycle. You'll usually be contacted very quickly within maybe 48 to 72 hours, so there's no time that have lapsed. It is this public pathway system, it's slow, but it is getting better. It can take between 6 to 8 months from when you first meet with your GP to when you're contacted by Sims Clinic. Unfortunately, that's out of our hands. That's all kind of external from Sims Clinic or any other fertility clinics. It's all done outside of our clinic and kind of run by the Fertility Hub. But that was the latest time frame I received this week. When another question you might ask would be, well, what is the criteria? How do I know will I be approved for the public scheme? It's as we kind of expected last November when it was introduced. It's strict, and loosely speaking, it includes a woman's BMI. So for a woman to be approved, for a couple to be approved for public funding for fertility treatment, they asked that the BMI is within a range of 18.5 and 30. For the female patient to be under 41 at the time of referral to the regional fertility hub, and the male patient under 60. The couple must not have any living children from their current relationship, and at least one partner must not have a living child. It's available to patients who've undergone a maximum of just one previous IVF cycle. And unfortunately, it's not accessible to same-sex couples or single female patients who are looking to use donor sperm. Sorry, I'm just going to go back to the slide for just a second. So I've already kind of said just a little bit about the time frame, but from when you meet with the doctor at Sims Clinic, you don't go through the same pathway as what a private patient would, because all of your investigations have been completed. We have the results available to the doctor and really a recommendation on the treatment plan as well. So it would be a case that once you have that consultation with the doctor, you'd skip straight to the nurse scheduling call and start your treatment cycle then at that point, or, at a time of your choice. I put this slide in just a little bit about our nursing team. We have a wonderful team of nurses, midwives, and healthcare assistants who work together with the multidisciplinary team. You'll see the nursing team kind of dotted around most of our departments, including ultrasound scanning, theatre and recovery. It's the nurses and healthcare assistants who do our blood tests. We schedule your treatment cycles, we educate you on your medication, and we're available to take phone calls, or I have the word salve there as well. That's just a communication app that we have for our patients who find it very, very convenient just to message in, like a direct messaging program. When you can't speak with your doctor, we're kind of happy to speak on your behalf or to arrange a consultation with you as well. And in addition to the nursing team, we have a wonderful multidisciplinary team with embryologists, administration staff, and doctors as well. So just moving on a little bit to investigations. So I always start with the male investigations because it's all of one slide. But for the male investigations, we will be performing a semen analysis for all male patients. With the semen analysis, the embryology team will examine 3 factors: the number of sperm per sample, the motility of the sperm, and the morphology or the appearance of the sperm in that sample. In a normal semen sample, you'd expect there to be 15 million sperm per milliliter and a normal volume of 1.5 mils. So when you add that up, it's like 45 million sperm per ejaculate sample. Again, in addition to the numbers, as I said, you're looking at the motility and the appearance as well. You wouldn't expect that all 45 million would be moving or you have normal appearance. With the semen analysis, the embryologist together with the doctor will then recommend a fertility treatment based on that result. For the female investigations, generally we would recommend a series of blood tests: an AFC scan, which stands for antral follicle scan, an SIS or hysteroscopy, which I'll touch on in a minute. And then there's always other, not for everyone, but for some patients. And this isn't applicable for all patients, but it can be for some, where 1 or 2 might be for one and another for another patient. So the main blood test that we do at Sims Clinic and most fertility clinics would be an AMH. An AMH, it stands for anti-Muller hormone. And an anti-Muller hormone, it's a protein that's secreted by the follicles in the ovaries. It gives us a good indication of the number of potential eggs that a woman would have. And it would help to dictate or to that information is very fruitful for the doctor to generate a treatment plan, and including the medication and the doses as well. An AMH will tell us if a patient has a low, a normal, or high ovarian reserve. Not every one patient you'd expect to have the same AMH result. And AMH, you can see on the graph there, an AMH, you'd expect a woman's AMH to decline with age, and that graph is reflected, or is reflected in that graph as well. So it is subjective to a woman's age. Other blood tests that we would recommend, it would be thyroid function. We would recommend all of our female patients to have their thyroid function checked. There's a little bit of research to say that women who have an underactive thyroid would be a little bit higher risk of miscarriage. So we just want to make sure that endocrine function is normal before starting into a fertility treatment cycle. And really, that's just preconceptual care for any patient, both proceeding with fertility treatment or not. We'd recommend a full blood count, particularly for patients proceeding with an IVF cycle. So if you think of full blood count, it's just like it's a general blood profile that looks at your red cells, your white cells, your platelets. So before proceeding with any kind of invasive procedure like an egg collection, we just want to make sure that our female patients, they're well, they're healthy in advance of that. For most of our patients, we would recommend to have day 2 to 5 hormone bloods. And those hormones are FSH, LH, estrogen, and progesterone. We would only really recommend to have those hormone bloods taken at that time in a woman's cycle, simply because they're easy to interpret, and it gives a good idea of what that woman's fertility is like in that given cycle. You might hear women have their progesterone checked around day 21, and that's perfectly fine as well. What that result tells you is if the progesterone is high and at that time, it confirms ovulation has happened in that cycle. For some patients, we recommend testosterone. Testosterone blood tests would be recommended for patients kind of in their early 40s and with a lower ovarian reserve. It's often a hormone that's affiliated with men naturally. However, as women, we all have a little bit of testosterone as well. And it is an important hormone because it, particularly with an IVF cycle, it helps for follicle recruitment. If with the blood test, the testosterone level is low, the doctor would recommend a short period of testosterone supplementation. Another blood test is rubella. Rubella is just the medical term for German measles. Again, this is very much preconceptual care, whether you're doing fertility treatment or not. We'd recommend all patients to have the rubella immunity checked in advance of having a pregnancy. Most of us in Ireland, certainly in Ireland at primary school, we all get the MMR, the measles, mumps, rubella vaccination. But even with that, some of us lose immunity. So it's important if they have just to get a booster again, because it can be very, very serious on the unborn baby if the woman contracts rubella in pregnancy. EU bloods, what EU bloods is, it's a panel of viral blood tests or infectious disease blood tests, including HIV, hepatitis, and CMV. It's requirement for all fertility clinics as part of our licensing body, that we do these bloods at the start of a patient's treatment cycle. And if needed, for further investigations might be required, but that will be very much on an individual basis. So you can see just from these blood tests that they're really not applicable to everyone. It's very individualized per person and per treatment cycle. A full blood count wouldn't necessarily be indicated for someone who's doing ovulation induction or an IUI, but would be for someone who's doing something more invasive like a IVF cycle. Just continuing with the investigations. So an SIS, it stands for saline infusion sonography, and it's a procedure that's performed in our ultrasound scan department that examines right inside the cavity of the womb to assess for the presence of abnormalities. So again, if a couple come to the clinic or a woman comes to the clinic and everything is coming up as normal, so the blood tests are coming up as normal, an IUI or a time section intercourse cycle might be something that's recommended. But before proceeding with that, we want to make sure that the uterus itself, the womb cavity itself, appears normal, and that the fallopian tubes are also present and they're working well. So this is when this procedure would be recommended. Hycosi, again, this is just an extension of an SIS where we assess the fallopian tubes and the patency of the fallopian tubes as well. When we talk about abnormalities of the womb, again, we're looking to see is there any little polyps there, any uterine fibroids or endometriosis. even with the presence of these abnormalities, it doesn't always mean that intervention is required. It's just kind of to take note and just to note that they're there and they're not they're not the cause of your infertility. This procedure would normally be performed between day 4 and day 10 of a patient's cycle. It takes maybe 15 minutes. It's quite quick, and it's generally well tolerated from a patient comfort point of view as well. Again, it's not recommended for all patients, but it would be certainly for a select few. So just moving on to different treatments. We have a range of different treatment options, including time sexual intercourse or ovulation induction, which would be really the same thing. Intrauterine insemination, the abbreviation for that is IUI, IVF, ICSI, or PGT, egg freezing, donor sperm, and shared motherhood. And I'm going to elaborate a little bit on each on the next few slides. So time sexual intercourse or ovulation induction, this would have an approximate success rate of about 17%. It's generally advised for patients who are that bit younger with no obvious reasons for infertility. So going back to my kind of first couple of slides, they fall under that 25% who have unexplained infertility. And it can often be recommended. It's a really good treatment option for patients who have irregular cycles. So you often find women who have PCOS, it's an abbreviation for polycystic ovarian syndrome. They can have very long cycles and they don't quite know when they're ovulating, which is really the main reason that they're not getting pregnant. For this type of cycle, you'd expect a patient to have approximately 2 ultrasound scans. It's generally a medicated cycle. So instead of just kind of trusting a woman's body to release hormones for an egg to grow and ovulation to occur, we tend to prescribe medication to enhance follicular egg development. At the ultrasound scan, we're looking at the lining of the womb, we're looking at the response from the medication in the ovaries, and we see that a follicle reaches a certain size that we expect to be a mature egg, we then advise the patient to take what's called a trigger injection. And this injection is designed to cause the body to ovulate. You'll notice I'm going to mention the word follicle and egg kind of interchangeably. As women, we're kind of very used to the word egg. You know, we ovulate every month, our body releases an egg. But I will be using the word follicle quite a bit. And the reason being is that when we're doing ultrasound scans, we can't see eggs on scans. On scan, eggs are microscopic. So we're guided by what's called the follicle. And what a follicle is what I describe as like a shell that surrounds the egg. And at the very start of a woman's cycle, the follicles are really, really small. But as we get closer to ovulation, the follicle will grow and grow and grow. So you'll find that I'll use that word quite a bit. So just wanted to explain it before I move forward. Another treatment option is intrauterine insemination. So again, we love abbreviations in nursing and healthcare, but the abbreviation for that is IUI. The success rate would be anything up to 23%. It would, similar to the time sexual intercourse or ovulation induction, would be a medicated stimulation cycle. The IUI itself is performed by a nurse, and an embryologist would prepare the semen sample that morning. I put the times down just because some people like to know that, but it's normally performed at 11 or 11:30. There's no sedation required. It's a very straightforward procedure, and there's time off work is not necessary either. An IUI cycle, just for your own information, it's, as I already said, it's a medicated stimulation cycle. It's a little bit similar to IVF in terms of the injections that you might take and the ultrasound scans as well. But the difference being that would be it's a much smaller dose of medication that will be used during the stimulation phase. So the stimulation phase is a phase from when you start taking your injections to when you have your procedure itself. So stimulation referring to stimulating the ovaries. Unlike IVF, so with IVF, you want as many eggs as possible because we're going to physically remove the eggs outside of the body to fertilize them. So with IUI, the goal would be to have 1 follicle or egg, or a maximum of 2 at the time of ovulation. The reason being that any more than 2 would put a woman at risk of a multiple pregnancy. More than 2 to it, like we're looking at triplets here. So most patients are very understanding of that, but that's why we prescribe a much lower dose. Similar to the time sexual intercourse cycle, once the follicle reaches a certain size that we think there would be a mature egg there, trigger injection is prescribed to cause ovulation to happen for the IUI. I beg your pardon, on time for the IUI procedure. With the IUIs, treatment cycles, they're generally recommended for younger patients or patients using donor sperm. It would be very much an option for patients using donor sperm. once a patient has had an IUI procedure, they'd be recommended then to take a pregnancy test 2 weeks later. For IVF ICSI, so again, the IVF and the ICSI, these are sometimes used interchangeably as well. The process for a couple is the same. The difference between IVF and ICSI is how the eggs are fertilized. So for IVF, it's in vitro fertilization. The eggs are placed in a petri dish with a sperm, and the sperm is to freely fertilize the eggs themselves. IVF would be recommended for patients with a normal semen sample. For ICSI, it's a little bit more invasive. If there's any kind of abnormalities with the semen sample, generally ICSI would be recommended. The difference with ICSI is that instead of letting the sperm and eggs meet themselves in a petri dish, the embryologist will examine the semen sample under a microscope and physically choose the best sperm, in their opinion, to fertilize the eggs. Once they've chosen that the better sperm, they'll inject the sperm into the egg and then check for fertilization the next day. But outside of that fertilization component of it, all of the steps are the same. With IVF and ICSI, it's maximum success in minimum time. I often get asked this question: what are the success rates? I don't have an answer because they really vary from person to person, depending on age, AMH, history, all of that. So they do vary, but we do see maximum success in minimum time, as I said. With an IVF or ICSI cycle, it can result in multiple embryos for subsequent pregnancies. So some people can proceed with an IVF cycle or an ICSI cycle and achieve many embryos, and only have to therefore go through that stimulation egg phase and egg collection once, and would just proceed then with frozen embryo transfer cycles thereafter. It does, of course, have that diagnostic benefit to assess egg quality when we see the embryo developing as well. In terms of monitoring treatment cycles, so you'll find an IVF ICSI cycle and egg freezing cycle, which I'll touch on in a minute. It'll from when a patient comes to the clinic and starts her treatment cycle, it'll take anything between 10 to 14 days of this patient having injections. The injections, they're synthetic versions of the hormones that as women we naturally produce, so which would be FSH, follicle stimulating hormone. You'd expect these patients to have anything between 3 to 4 ultrasound scan appointments during this time frame up until the egg collection procedure. The scans that we perform, and this applies for all our treatment cycles, they're mostly transvaginal ultrasound scan or internal scans. So there's great care and sensitivity taken when we're doing these scans, and some patients are perfectly fine with them, and really others, they just need a little bit more time, a little bit more reassurance, and that time is taken for them as well. Our scans, they're performed Monday to Friday, mostly in the morning times as well. And as Aoife said at the beginning, we do have satellite clinics for where patients, they don't live kind of all that close to the main clinics, and they are based in Carlow, Limerick, and Dundalk as well. This is just a step-to-step guide of what actually happens for an IVF or ICSI cycle. So you'll see here, step 1, egg production stimulated by hormone therapy. So this is that phase that I touched on where you'd expect a woman to be on FSH injections from a period of maybe 10 to 14 days. Just to kind of elaborate a little bit, sometimes when you mention injections and for a prolonged period of time, it can be very anxiety provoking, a little bit feel quite fearful. The injections, the nurses will educate you on your injections. The injections have come a long way in recent years. They're very user friendly. If you've ever seen an EpiPen or an insulin pen, they're very similar to that. So it can feel a little bit daunting at the beginning for the first day or two, but patients do just fantastic with them. And we are, as nurses, as I said, we are here to support you with them as well. So as I said, step 1, you take your injections for maybe 10 to 14 days. You have 3 to 4 scans in that time frame. Step 2, eggs are retrieved from the ovary. So this is a procedure called an egg collection. Step where the eggs are collected. Step 3, a sperm sample is provided. So on the morning of the egg collection, if you have a male partner, your male partner will produce a semen sample that same morning of the egg collection. And step 4, the eggs and sperm are combined to allow for fertilization. So this goes back to, is it IVF or ICSI? So that's the only differentiation between that. And lastly, step 5, the fertilized eggs are introduced into the uterus. So also known as an embryo. It takes 5 days from the after egg collection for an embryo to develop into what we call a blastocyst. And at that stage, if a patient is proceeding with a fresh embryo transfer, that would proceed then 5 days after egg collection. So it's just, I kind of like this diagram. It's probably about 30 years old, and the language isn't great, but it kind of does break it down a little bit. Just about the egg collection procedure. The egg collection procedure is performed by a doctor, a fertility consultant, with the assistance of a healthcare assistant, and an embryologist will also be present as well to check the eggs as they're being collected. It's performed under sedation, and it's performed by transvaginal ultrasound scan as well. So similar to the scans that you would have had in this cycle, you will be asleep for this procedure. And we'll always make sure that you're at your most comfortable as well. So it's like any other kind of procedure that's performed under sedation, like endoscopies, colonoscopies. It'd be similar medication again. This procedure is performed at Sims Clinic. It's performed in our main clinics, so either in Clonskea, Swords, or Cork main clinic, and it's performed in the morning time. The procedure itself is actually quite quick. It's maybe 20 minutes, but we do allow for maybe like a 3-hour appointment slot. With that, it allows for time before the procedure, so to have a cannula placed in your arm, to address any questions that you might have with your doctor, and to fill in just the last signature of your consent form as well. It allows for the time for the procedure and then recovery after sedation as well. We would recommend time off work during the day, of course, for the day of egg collection. I personally recommend just take the next day off work as well. And at Sims Clinic, we're happy to give you a letter for that, be it on headed or non-headed paper. Usually, if you just take the day off, the day after, I find patients just recover that bit quicker as well, and you're fine to return to work then after that. PGTA, also known as pre-implantation genetic testing of aneuploidicity. PGTA, it tests our embryos for chromosomal abnormalities. It checks this biopsy, so this sample is taken when the embryos are developed, so either at day 5 or day 6, so either 5 or 6 days after egg collection. The sample is taken and sent to be tested, and it checks for the correct number of chromosomes per embryo. So you'd expect there to be 23 pairs of chromosomes in any normal cell, or 46 individual chromosomes. It wouldn't be recommended for everyone. Of course, it's more expensive, so it'd be more applicable for patients who maybe have had recurrent miscarriages or repeated failed IVF attempts. But it's a very good option available for certain patients for sure. For these patients, they wouldn't be able to proceed with a fresh embryo transfer. The results take maybe 4 weeks to come back, at which point you'd have a consultation with your doctor to discuss the results, and then hopefully to later plan a frozen embryo transfer cycle as well. With an embryo transfer, it can either be a fresh embryo transfer, which, as I said, would be 5 days after a woman's egg collection, or it could be a frozen embryo transfer, which for the likes, there's different reasons that we would recommend to freeze embryos and for those patients not to proceed with a fresh transfer, and that would be called a frozen embryo transfer cycle. Our embryo transfers, they're performed by a doctor with the assistance of a healthcare assistant, and an embryologist, of course, has a vital role of providing the good quality embryo as well to the doctor. Our transfers are normally performed in the afternoon. We would normally recommend a full bladder for this procedure. There's no sedation required, and time off work is also not necessary either. Generally after egg collection, regardless actually, if you're proceeding with a fresh transfer or frozen embryo transfer, you would receive regular updates from our embryology team to update you on the embryo development. So normally 2 to 3 days after egg collection again, and then again on the morning of your transfer if you're proceeding with a fresh transfer, or on the day of the embryo freeze as well. At the procedure for frozen embryo transfer, or for embryo transfer, I should say, it's a very straightforward procedure where a small catheter, it's passed through the cervix and into the womb. It's performed again by ultrasound guidance, but thankfully it's not transvaginal, it's an abdominal ultrasound scan, which is assisted by the healthcare assistant to ensure just the correct location of the catheter tip. And you can actually see the embryo, the little flash of the embryo passing into the womb as well. So it can be quite a nice experience for people. Egg freezing, just touching egg freezing. I touched on it very quickly at the beginning. Egg freezing is a form of fertility preservation. It would be the same process is IVF, ICSI, or PGT cycle. So what I mean by that is a patient proceeding with egg freezing would have the same number of ultrasound scans, maybe 3, 4 ultrasound scans, be expected to take injections for 10 to 12 days as well. And with the difference, of course, being that we're not creating embryos. So at the point of egg collection, the eggs are frozen and they are stored for future use, and maybe used later to conceive a child at a later stage. For other treatment options, including donor sperm and shared motherhood. So we work with a donor sperm bank in Denmark called Cryos. At Sims Clinic, we will provide you with all the details on how to pick the correct donor for you. What's important for one woman might be not so important for another woman, such as physical characteristics, education, family history, things like that. But we provide you with all the website details and the instructions as well, and it's all very user friendly. When using donor sperm, it opens up the option of IUI or IVF, and the doctor will be in a position to recommend what will be best suited to you. We also have a program called Shared Motherhood. It's when for same-sex female couples, and what it is one female partner will proceed with the ovarian stimulation. So that's the stimulation of the ovaries to grow and collect as many eggs as possible. When the eggs are collected, the eggs are fertilized with donor sperm, and the resulting embryo is then transferred to the female partner's womb to hopefully result in a pregnancy. So it can be a really nice option for many couples. Last slide. Just additional support. What can I do? So the impact of treatment on a person can really just varies from person to person. For some people, they come to our clinic and honestly, they feel a bit of a weight has been lifted off their shoulders. They've been trying to conceive for some time. It's really just impacting, and it's really starting every month with that negative pregnancy test each time. So it can feel like a little bit of a weight has been lifted off their shoulder, that the responsibility has kind of shifted to someone else, which could be quite nice. But it can have impacts on a person financially, physically, emotionally, psychologically. We do have a counsellor on site at our clinics. It's not for everyone. There's no obligation to speak to or meet to a counsellor, but for some people it can be really helpful and really nice to kind of have that conversation with someone you don't know on a personal level. Have a vent. That's what she's there for. And yeah, it can be quite a nice option. As I said, there's no obligation, there's no pressure to have counselling. Of course, like anything with any preconceptual care proceeding with pregnancy, we would recommend a healthy BMI, and with that, a healthy diet, no smoking, to limit your alcohol and your caffeine intake. I touch on counselling, just general self-care and taking care of yourself and your partner if you have a partner, and just walking and doing things that you enjoy. I always think like it's some patients come to the clinic and they're on a strict diet and they're not meeting friends, they're not meeting family, and everything's on pause. It's like that can work for some people, but not for everyone. You still have to kind of live your life and do things you enjoy, and that's really, really important as well. Do know if you do proceed with us here at Sims Clinic, we are here to support you. We have a fantastic multidisciplinary team. We have a dietitian as well who's based in Carlow. But yeah, whatever we can do to help you along the way, we will go above and beyond for you. Thank you very much.
So much, Clara. I feel like I always learn something new on these webinars myself.
That's good.
Yeah. So we've got, if people want to submit questions, you can pop them into the Q&A box at the moment. So we have one question here already. So for time sexual intercourse, is it recommended for younger people, or what would be the cutoff age typically?
Yeah, it would generally be recommended for younger people, as I said, and for couples where the investigations have come back normal. So with that, you'd expect a normal semen analysis, within reason, a normal AMH. I kind of mentioned it's often suitable as well for patients who have a regular cycle. So generally, there is a reason that they're not conceiving, and that's because they're not having intercourse at the time of ovulation. I do get asked this question quite a bit. What is the cutoff age? There is really no cutoff age, to be honest. Like 25, 26, 30, 31, 32, they're all reasonable ages to proceed with the time sexual intercourse cycle, you know. And as I said, the doctor would be the best person to recommend when they have your results available, but there is no actual cutoff. And I should say as well that if you feel strongly that you really want to do a time sexual intercourse cycle, you're perfectly within reason to kind of advocate for yourself to say, you know what, doctor, I actually just want to try this, if that's okay. And that's perfectly fine as well. Of course, the doctor will recommend what they feel is the best course of treatment for you, though.
Perfect. Thanks, Clara. Another question in here. So how long should I be off the pill to go for testing?
Maybe 6 weeks. Usually, so with the oral contraceptive pill, it can kind of just really quieten down your ovaries. So if you were to go ahead with an AMH blood test, very quickly after stopping the pill or while on the pill, I don't expect the result would be accurate. So it's probably best to wait kind of 4 to 6 weeks from taking the from taking the oral contraceptive pill to do those tests.
Perfect. Thank you. So this person here, so for someone with a low FSH, would there be a series of medicines injections before further treatment of IVF?
A low FSH is generally okay. So I touched on the investigations earlier. So we generally recommend an FSH to be tested between day 2 and day 4 of a woman's cycle. There would be more of a concern if the FSH was very high. So with a low enough FSH, I wouldn't be very worried. Sorry, you might repeat that question though, if I feel I only half answered that. What was the second half of that
Yeah,
question?
they said, would there be a series of medicines or interjection before further treatment of IVF? I mean, yeah. I'm wondering, do they mean like, do they need extra injections before starting
No,
the treatment?
no,
Yeah,
no is the answer. No is the answer.
yeah,
You'd normally expect your FSH to be on the lower on within the normal range would be low anyway. So that all sounds very normal to me that that person wouldn't be required to take additional medications on top of the stimulation injections prescribed for an IVF cycle.
perfect. It's good. No, if there's any more questions, we'll hang on for a minute or two and wait to see if there's any more popping through. But I suppose did we touch on waiting times at the moment, just for kind of if you're going down the private route at the moment?
Yeah, that's good.
Yeah.
So generally what will happen is when you go onto our website, you request an appointment, you'll be contacted by our patient coordinator very quickly, within a day or two, to be totally honest, and a consultation will be booked for you. If you choose to go ahead with fertility packages, though it's kind of cycle dependent, to be quite honest, those investigations. So the fertility packages would include an AMH, a semen analysis, and an ultrasound scan. We've loads of availability for them. To see a doctor is maybe 3 to 4 weeks, but it does give time to kind of collect results and investigations as well. But waiting time at the minute is maybe 3 to 4 weeks to see a doctor.
Yeah. And you would recommend, and I think it does help to kind of complete those investigations before seeing the doctor for your initial consult, because at least they have more information rather than if you just go
Yeah,
straight for your initial consult.
that would be
Yeah.
my recommendation, to be quite honest. And
Yeah.
it's not for everyone, so you kind of have to feel comfortable. It can take a lot of courage just to make that
Mm,
first step to pick up the phone or to click the option for initial consultation. So it has to feel right for you. So if just going to the consultation without any results feels feels like you're at your limit, that's what you just need to
mm,
do. But if you feel you can kind of, really want to get the most, if you want to be really proactive about your fertility and proceeding with fertility treatment, I would recommend to have some investigations done in advance. So, as I said, that can be discussed with the patient coordinator when booking the initial consultation. As I also mentioned, and I be a little bit like this, you kind of think, oh, they just want to sell, sell, sell. They are actually at discounted prices. So it would be advantageous to kind of take them up on these different fertility packages as well. There's only two fertility packages that I know of. One is a female only, and the other is a couple fertility packages. So with the couple fertility package, it would include the male semen analysis, including the female investigations, and with the female only, it would be an antral follicle count scan and an AMH blood test, in addition to the consultation with the doctor for both.
perfect. Then someone saying thank you so much. I feel a lot more hopeful after that. So
Oh,
that's a
thank
nice
you.
going
That's really
start.
nice.
And then someone else is asking, what's the success rates in your clinic for over the age of 38? I do have just the success rates from our website. We do have them published on there at the moment. So we have done, in regards to from 38 to 39, you're looking at between 38% and 45% success rates. And this is when we say success rates, we're looking at clinical pregnancy rates. Um, so yeah, you can check that out on our website. We do have it up there. We have our IVF success rates there. If you want to find out a little bit more information, they're there. And I think that's all the questions that have kind of come through. If you want to kind of maybe ask your question offline, I know sometimes people are a little bit more comfortable asking questions offline. I will be sending an email either tomorrow or the next day just with a link to this recording. If you want to kind of look back on it. And then also if you want to submit any further questions, or if you want to go ahead and maybe book an appointment, so that's I'll send out that information around if you want to ask further questions. So we're happy. The nursing team are great for answering any questions you may have. So yeah. So I just wanted to thank you all for turning up tonight. I know it's a kind of an hour out of your evening, but I hope you all found it informative. And thank you so much to Clara. You did an amazing job there, and it was I found it, for me, I'm always learning, and it's great to learn from the best.
Thanks,
So
Eva. Thanks so much for hosting.
no worries. Okay, thanks very much, guys. Have a
Thanks.
lovely evening. Bye. Bye bye.
Thanks. Bye bye.